speaker. So, and let's welcome the Professor Williams Huang to moderate the next speaker.
Thank you. This is a very interesting topic to discuss the PRP used for erectile dysfunction. The next speaker I would like to introduce is the Professor Liao Junhou, and he is now the professor of urology of Furen Catholic University Medical School, and also the president of a Taiwan Continence Society. And we know he is very famous in treating continent patients, and also very good research in andrology field. And he has already some research projects working on PRP for erectile dysfunction. Now, we would like to ask him to have a talk on the Taiwan Real-world Experience. Dr. Liao, please.
Thank you, William. It's my great honor to attend the Congress and present here. Today, I will talk about PRP for ED, the Taiwan Real-world Experience. First of all, I will introduce my personal experience about short-term follow-up of intracavernosal injection of PRP for ED. This is a prospective single-arm study. We enrolled 30% patients from 2018 to 2020. All patients had poor response or unsatisfied with PDE5 inhibitors. 30 milliliter blood were drawn, and we used dual spin PRP. Around 2 milliliter of PRP was slowly injected in each corpus cavernosum. We only inject one side at each side. So I only injected two injection points used. And we use 3 sections of treatment with 1 month difference were performed for all patients. Although PDE inhibitors were used in some patients, or testosterone replacement around half of these patients because they had hypogonadism without a change in dosing were permitted during the treatment period. Efficacy was assessed every 2 weeks after each treatment session, including IF5, erectile hardness score, sexual encounter profile 2 and 3, and the global assessment question. Any adverse events were recorded. This table shows the baseline patient characteristics. The median age was 54 years, around 80% elder than 50s. The median BMI was 25. 30% of patients had smoking, 40 had hypertension, 16 had diabetics, and 10% had CAD. 2 patients had received previous pelvic surgery, included HIFU and LRP, but these 2 patients had poor response to PRP injection. Around 3/4 of patients used PDE5 inhibitor during the treatment period. After PRP injection, the IEF increased gradually after the first PRP injection. The baseline IEF, mean IEF was around 11 point after the first injection to 13, 14 after second injection, and 16 after third injection. The EHS score also increased from baseline 2.3, 2.5 after first injection, 2.7 after second injection, and 3.0 after third injection. The initial positive response to SEP2 was around 33% of patients. After 3 sessions of treatment, the positive response to SEP2 was 90%. Initially, only 30% of patients had positive response to SEP3 question. After treatment, 83% of patients had positive response to SEP3 questions. Initially, 56% of patients had moderate to severe ED. After treatment, only 20% of patients had moderate to severe ED. This figure shows the change of IIF and the EHS. Initially, no patient report an EHS score of 4. 30% of patients can achieve full rigidity and complete hardness EHF of 4. For SEP2, 73% of patients able to insert their penis to partner's vagina initially, and after treatment, 90% of patients can insert their penis to their partner's vagina. Initially, 30% of patients had erection less long enough to have successful intercourse. After treatment, 80% of patients can do this. Overall satisfaction, 80% of patients thought PRP therapy improved erections. So according to our single-arm prospective study review, our preliminary experience with intracavernosal PRP can significantly improve erectile function without obvious adverse events. However, double-blind randomized placebo-controlled clinical trial are needed. Fortunately, we can find one placebo double-blind randomized placebo-controlled clinical trial this year in Journal of Sexual Medicine this May. 60 sexually active patients with mild to moderate ED were randomized assigned to 2 sections with 1 month difference of 10 milliliter PRP or placebo intracavernosal injections. They enroll patients only mild to moderate ED and they injection only 2 times, but the interval is similar to us, 1 month difference. They use an FDA-approved separation system, and the patient will evaluate 1, 3, 6 months after completion of the treatment protocol. Also, their patient withheld any ED treatment during the trial. In addition, a patient with previous major pelvic surgery or trauma, previous major penile surgery or radiation, history of pre-episode penile fracture, Peyronie's disease, penile curvature, or hypogonadism or psychogenic ED were included in this study. This study is supported by ESSM. They use the PRP processed by an FDA-approved autologous platelet separator, Magellan autologous platelet separator, to yield approximately 10 milliliter of PRP. I think this separator cannot be found in Taiwan yet. The study, previous study showed that among available commercial PRP separation system, Magellan system offers high quality PRP. So I think the quality of PRP is very important for the treatment. And their injection method also different with us and Dr. Jiang's study. They use a penile tourniquet clipped around the base of the penis. A total of 5 milliliter of PRP was infused in each corpus cavernosum. They slowly retracting the needle for better distribution of PRP into the erectile tissue over 2 minutes in period to minimize platelet cell injury. Because if we trauma the platelet too early, maybe the growth may be really too early. So they use slowly injection and slowly retracting method. Following the administration, they use additional compression of the penis with a dressing placed around the penile shaft, and the penile tourniquet was removed 20 minutes after the injection. And the patient were instructed to remove the compression bandage at home 4 hours after the injection. The outcome were evaluated by the achievement of minimal clinically important difference in the IIF, EF from baseline to 6 months after treatment. At 6 months, the MCID was achieved by around 70% of patients in the PRP group and only 27% in the placebo group. So the risk difference between the 2 groups was 42%. And the baseline adjusted mean between group difference in the IIF, EF score was 3.9 points. Patients receiving PRP were more satisfied with the treatment and no adverse events were observed during the study period. So they concluded that intracavernosal PRP injection therapy used as outlined in this trial to be safe and effective short-term treatment for the management of mild to moderate ED. When we compare our study with this placebo trial, although the study design, patient enrolled, injection method, and the PRP use are different, all these patients had minimal or nearly no adverse events. And the mean EREF improved significantly in both studies. So I think maybe PRP for ED, more evidence, this evidence can show the benefits of PRP for ED. However, there are still some questions about PRP for ED, such as the exact mechanism, who is the best candidate, and which kind of PRP we should to try, and the injection method difference and the treatment protocol difference, and also very important, the treatment durability is still lacking. We all know growth factor in platelet is very important in cell proliferation and angiogenesis. I think Dr. Jiang had shown that. And several studies had shown that growth factor can moderate nerve degeneration after cavernous nerve injury. In addition to growth factor, cytokines also play an important role in tissue repair and degeneration. In our previous study, we showed that CXCL5 and the CXCR2 as mediators of PRP effects in the preservation of erectile function after cavernous nerve injury. However, the concentration of cytokine and growth factors are different with different PRP kit. So we think using different PRP kits may lead to different treatment results. Single spin PRP kits usually use a soluble polymer two-thread fiber treatment. However, the pre-concentration may less than that of the whole, but not as good as the report. And the second round of centrifugation can result in a highly concentrated PRP. And the concentrated PRP may up to 6 or 7 times of whole blood. A previous study has shown that single spin PRP may have less effectivity in alopecia. So in addition to the type of PRP, there is still no universal injection method or treatment protocol. How many sessions are needed? 2 or 3 or 5, as Jiang said. And what's the interval? Every week, every 2 weeks, or every month? But both us and the study in JSM use injection every month. I think every month may be enough to PRP injection. And how many injection? 2 injection points or 6 injection points? Shall we use tourniquet or peanut clamp or additional compression? There is still unknown about that. So in conclusion, PRP intracavernosal injection may be promising addition to the urologist armamentarium for the management of ED. However, this result may not be extrapolated to all PRP suppression symptoms. There are still controversial about best candidate, types of PRP, injection method, and treatment protocol, and also treatment durability. Further high-quality studies are warranted. Thank you for your attention.
Thank you, Professor Liao. I have one question for you. Should the PRP, I would like to ask the combination effect. Is a PRP, how do you think the PRP can help to enhance the effect of a PD-5 inhibitor, or some patients enhance the effect of low-intensity shockwave? What's your opinion?
In fact, I don't know. But I think I had seen a study that combined the PRP and the shockwave. The results may be better than shockwave only. But I don't know the real mechanism because the mechanism of shockwave and the PRP, both of these are tissue regeneration or angiogenesis. I think there may be a combination effect. But for PDE5 inhibitor, because the mechanism is different, so I don't know if there any synergistic effect between PDE5 or PRP. So that's what I know. Sorry.
Oh, thank you. So it seems that there is something that we can do that to answer questions.
Yes, maybe we can do more basic study for that. That's maybe another proposal next year. Please help.
Yeah, thank you. Is there any more questions from the colleagues?